I hope you see it.
Yes, perfect. We're seeing it.
I am sending you greetings from Valdoltra Orthopaedic Hospital, based at the beautiful beaches of Mediterranean Sea. While in Finland you still enjoy the winter, we have the first signs of spring already coming to us. So I'm located just at the Italian border, at the tip of the Mediterranean Sea. If you know this area, you're most welcome to visit us in winter and summer. There's something to do. I'm chief of foot and ankle department in this biggest Slovenian orthopedic hospital. And as I was announced before, I have now more than 10 years of experience with RegJoint implant. And in some cases, as you will see later, it was lifesaver. So I hope you're all foot surgeons and you know these basic commandments in foot surgery. So when we finish with our job, the foot should be aligned, stable, painless, and being able to wear shoes. Of course, the population of our patients is getting more and more demanding. So, of course, nowadays they also ask for normal appearance. So aesthetics might be indicated. And of course, they demand mobility in crucial segments. About ankle mobility, we know from robotics, we know from the data, from the studies that fused ankle is limiting activities and can be life-changing. We know that our body fights back, so people want to have ankle, they want to have a mobile segment at this level, but how is it at the distal foot? Where there is another very important mobile segment. And if we observe our not so typical patient, she is squatting and we see motion at the metatarsophalangeal joint line. And of course, we can do our job with some rocker sole shoes. We can get our patients in good function with such type of modification. But in case of some trouble, patients usually prefer to have their joints mobile. So ideas like this that have been proposed and published sometimes are not acceptable. So in a lot of cases, we are lucky and we can do joint preserving surgery, like in this case of Morbus Freiberg, where we were able to end with an osteotomy and get a good functional joint preserving result. But on many occasions, we get patients with such extensive joint disease, where, of course, if we look Smiley's classification, in end stage of arthrosis of the joint, it is hard to talk about joint preserving because the damage is too vast for the joint to be sacrificed. So what are our options? Partial proximal phalangoectomy and syndactylization was tried and rendered poor results. Fusion, as proposed before, can only be done in case of concomitant MTP1 fusion. So in isolated cases, we have no option. Amputation is maybe acceptable for older patients, but the aesthetics is questionable. So we go more to the main field surgeries, which used to be head resection. This provides good functional results, but it's very problematic when a lot of heads are resected. So one isolated head resection might be tolerated, but aesthetics is poor because always the ray becomes very shortened. So I think more or less nowadays, what is the golden standard in such cases is some modification of Duvry arthroplasty. Modifications are many, and this Duvry arthroplasty actually is functioning as a slightly shortening intrametatarsal ostectomy with interposition of some sort of soft tissue. If we continue and if we analyze our biomechanics of the joints of lesser race, we see that initially we have rolling motion in the joint. So there is a center of rotation and one part of the joint rolls around the second bone. If we are talking then resection and interpositional arthroplasties, the mechanism of function changes. And we get the function through bending. And of course, the higher the amount of bending, the bigger must be the gap. This is a physical rule. If we analyze the bending, the amount of bending is proportional to the square of the length of the gap. So if we have bone, bending segment, and another bone, the broader the segment, the bigger the bending. So for us, this means range of motion. And this is very important to keep in mind because abundance of soft tissue in between the bones will render our joints more mobile than scarceness of such tissue. Of course, we can do anchovies from tendons where we can sacrifice a little bit of collagen. Foot surgeons usually take bits of foot tendons, but we have to think about the donor site morbidity in these cases. And of course, we always have to think about limitation of such tissues available. Then, of course, if more is needed, nowadays we can buy allografts of Achilles tendon, for example, and we had good quality collagen, but this comes also at a huge price. So, in case of such patients, if we ask bioengineering to do something for us, we need an implant that would maintain the bone distance, an implant that would allow motion, would stimulate the soft tissue ingrowth, so this construct will be strong. There will not be luxations. It would allow vessel formation, and once it's not needed, it would fly away, so it would be degradable. Of course, it must be biocompatible, and of course, synthetic if possible, because with allografts always comes a little bit of risk of course, infection transmission. So RegJoint was already introduced to you, and it is a lactic acid polymer, so it ends up metabolized as water, CO2, and energy. So you can consider it as a food. If we see scarring, we know that scarring has several phases. One of the crucial phases of scar maturation is the shrinkage of fibrous tissue. So no matter what we do, if we leave our body just with a scar, the gap will shrink. So the gap that we desire, the gap that is our functional basis for the good range of motion, it will become smaller with time. In this period of 20 to 40 days after the surgery. So in this time period, we need something that is working against the shrinkage. And this is the main function of the implant. So the scar that is formed stays broad. The surgical technique for the implantation of RegJoint in lesser array or in all MTP joints is pretty easy. The approach is similar to what you would do for example, vilosteotomy. Then, usually we resect just a slight bit of the metatarsal head. The amount of resection is usually about 4 millimeters, which is the normal width of the implant once implanted. On the phalangal part, usually we leave the intact cartilage as for the Duvry arthroplasty. So actually the technique is the same, just we don't take the soft tissues from the surrounding, but we take a soft tissue scaffold that is available off shelf. It depends a lot upon the case to case where we do our resection, and I will talk about this later. But in a simple, non-deformed case, we usually approach through the extensor hood. We move the extensor tendons to the side. We incise the capsula. We do the osteotomy. We implant the implant, and then we meticulously suture layer by layer to reconstruct all the soft tissues. The use of K-wire is debatable. I usually like to use them. Many surgeons don't use them, especially in the non-deformed cases where there's no tendency for the deformity reoccurrence. If there is deformity, of course, I would recommend the use of temporary K-wire for a few weeks until the soft tissues settle down. So in this theoretical part, I would also like to show you my clinical experience. I am terribly sorry for the age of data. I have seen that this is actually pre-COVID data. I'm very sorry because after COVID, the last 5 years, we've been so busy with clinical work that we did not do any of our retrospective analysis. I hope that I get 10-year results maybe after this summer. But anyhow, my first experience, cases are extremely good. And I would like to present clinical data of those cases. So we did in 3 years 67 implantations in 42 patients. Majority of them were female. Some of them were isolated. Many of them were combined. So this means multiple race. The majority were primary cases, but revisions were also frequent. And the indications were arthritis, joint luxations, AVN of metatarsal heads as Freiberg disease. So you will see those cases later. The distribution of our patients was, the majority of them was metatarsophalangeal joint of lesser race, predominantly also of the first ray, but also the indications were for use in the Lisfranc joints of the lesser race. This indication for me in the last year is becoming more and more important with good clinical experience. In elder age, we are doing more and more TMT2 and 3 arthroplasties. In ladies of 75, 80 years, the fusion is hard to achieve, and arthroplasty is very fast and functional surgery with extremely good clinical results regarding pain. So our pain scale was extremely reduced after the surgery. This was done at 3 months. I will explain you why sometimes in average at 3 months, it might not be the best period to check the patients, but still there was extremely good subsidence of pain. Foot function measured by AOFAS score was extremely good, 85 in average. So it was from 70 to 100. As you will see the cases, you will see why some of them still remain 70. You will understand what my patients were and still are, because I work in a revision center. So sometimes we aim for 70 and patient is extremely happy. The major improvement, statistically, also the most significant improvement was in the disability. So the disability foot and ankle ability measurement score went to the normal range in all of the patients. So you see AOFAS sometimes is problematic because it measures range of motion, and sometimes patients don't get points because of the fusion or something like this. But disability is what we want for our patients to disappear, and we want to enable them normal life. So this score was for us very important that it got so hugely improved. Regarding the safety profile, we had some complications, of course. There's no surgery without complications, but some of them were minor. I mean, all of them were minor. K-wire migrations, incidental pull-outs, prolonged wound healing, some low perfusion problems at the beginning. We maybe didn't shorten enough, and a little bit of pin tract infections, but zero late complications like revisions, deep infections. In 10 years, of course, I did revisions. I did revisions of the RegJoint, but I think I still know the names of all of patients, maybe 4 or 5 of them. So it is very rare you have to revise this patient. However, a lot of patients come back in period from 3 to 6 months, or here 4 to 8 months. So this is when the implant starts to degrade, and they have some symptoms that I will explain you about. So this is the usual pain profile of our patients after implantation of RegJoint implant. And of course, the pain after surgery is significant, but when the swelling subsides, when the time passes by, at about 6 weeks, pain is almost gone. And in the period of 10 weeks, usually the pain is totally gone. And then patients insist of doing the physiotherapy. They want to do it, they love to do it, although I nowadays advocate against any physiotherapy in those patients. And then the pain starts to occur. And this is implant degradation pain, because at 3 months, 4 months, 5 months, in this period, if you force the joint, the implant will start, of course, with the breakdown. And a lot of lactic acid will be going away to the surrounding tissue, and you will get chemical acidic irritation, which usually is treated with non-steroid anti-inflammatory drugs for a few weeks and goes away, and then it never happens. But you must tell your patients about this, otherwise they will come for revisit, and sometimes they're unhappy because they really don't like pain. Of course, it's normal, but if you tell them in advance, then they know, they expect it, they avoid exert rehabilitation. Usually it's enough just to let the foot adapt to the new situation. So no forcing, in my humble experience. So now I would like to go to the more interesting part, and I will show you what we treat. Some cases for you might be strange. I don't know where you come from, but my background is a revision foot and ankle surgeon, and I have to treat any foot patient in the country, more or less, because we are a referral center. So we don't have the option to say, no, go away. We cannot send, so some cases will be really extreme, and I hope you will like those cases. So we start with medical stupidity. Some surgeon said, oh, the 5th toe is like the 1st toe, and he attempted to fuse the 5th MTP one. This, of course, is total stupidity, especially so if you do it with 2 K-wires. I think the fusion of the 5th MTP joint is achievable, but it's stupid to try it because it will be very limiting for the patient, and it will change his gait and will be, of course, very problematic. So in this case, there was a lot of stiffness, and of course, the non-union was painful. And this was a young climber. You see from the foot shape, he has cavus foot because of very strong foot muscles. And this was extremely debilitating for him because otherwise he wanted to be active, young, and going back to sports. And the procedure is extremely simple. We resected the non-union. We implanted the RegJoint implant, did K-wire for a few weeks, and the X-rays are nice. So this is immediate after, let's say, 3 months, and this is 1 year follow-up. So since there was no deformity, we didn't use K-wire, we used strapping, but it doesn't matter. So what I want to stress is that this guy returned back to climbing, and he didn't have pain, and he had normal range of motion, because usually the gap permits the range of motion similar to other arrays. It's not perfect, maybe it's slightly less, but not limitingly less. So similar case, very similar case, but here no previous surgery, but distracted fifth MTP joint because of the psoriatic arthritis, and the patient had problems because the fifth ray was a bit short. So here we did stack of 2 implants, a bigger gap to get a bit better position of the fifth toe, K-wire for several weeks, and again, good result. So now we come to the more often situation, more often scenario. This is patients with rheumatoid arthritis, with long-standing untreated rheumatoid arthritis. Our country is in the center of Europe, so in your countries maybe the healthcare can be better, but we treat a lot of patients coming from the Balkan regions, poor countries where rheumatoid treatment was not readily available for a long time, and we get such terminal conditions where luxations of joints and arthritis are extensive. So we did a similar approach that I think everybody would do. We repositioned the first ray, we fused the first ray, and we did the arthroplasty of the second ray. And this patient was also very satisfied. So more extreme cases, ankylotic, MTP, arthritic IP, and extreme toe deformity. So approach is more or less the same. We try to fix the first ray first in the functional position, slight dorsiflexion, neutral rotation, slight valgus, and then we try to respect the maestro's parabola. And here you see we did realigning of the first ray because it was fused in unacceptable position, and then arthroplasty of lesser rays with shortening, so that we get the nice parabola of toes, and of course, nice parabola of metatarsal pseudojoints. A case that I already showed you before, so Freiberg, I don't know why, but this is quite common in our country. So probably one in 10 hallux valgus cases has previous Freiberg disease. I don't know why it's so frequent, maybe some genetic reasons, but it is really frequent. And here we did nice first ray reconstruction, again, nice gap and good functional outcome. Another rheumatoid case. And then, of course, we started discussing what to do about the first ray. And the patient said, could you enable me to have some range of motion also in the first toe? The IP joint was, I think, very stiff. So we decided to do all fifth rays. Here, the maestro's parabola is not so perfect. I admit that I think I shortened too much on the fourth ray, but these patients are extremely satisfied when they have toes that can go in the shoe, they have slight range of motion, and they are painless. So all those patients are extremely satisfied, even though the x-rays don't look so perfect. But this foot is actually aligned, painless, stable, and shoddable. So we checked all of our marks in our demand list. The list of rheumatoid patients goes on, so maybe I will skip them because these are similar. So here is an interesting case. This case developed ankylosis of fourth TMT joint. There was previously frank injury treated with primary fusion. And during the follow-up, the lady developed isolated ankylosis of the fourth TMT joint, which was very painful and very debilitating because her adaptability to the uneven terrain was limited. We know that this lateral column is crucial in adaptability. So because she was painful, we decided to do the resection interpositional arthroplasty, and this was our first case in the fourth, fifth TMT joint, and the improvement of a range of motion of the lateral column was incredible, and the patient was extremely satisfied. She became painless, and she was able to walk normally, even on uneven grounds. There is another medical stupidity. You see, there was a surgeon who treated patient with previous ankylotic IP joint and arthritic MTP1, treated with MTP fusion. Of course, this cannot function. This is so limiting because IP joint must remain mobile after MTP1 fusion. So this lady was unable to put her foot in the shoes. She needed special shoes. She usually used just open shoes. So what we did a takedown. How did we plan a takedown? We planned it more or less like Valenti arthroplasty with a little bit of wedge resection in the dorsal bits and also interposition. Where is the video? Oh, here. Okay, so and there is another case very similar. Arthritis of the MTP1, poor reconstruction. You see just scarf osteotomy, unaligned joint, varus configuration of the joint, and this went into very fast arthritis. So both cases were treated in a similar manner with resection arthroplasty. And now I have a video that I think will tell you the most about RegJoint implant, because if you observe it, you see what is going on. And this spongy tissue inside the joint, this is your RegJoint, and you will see it helps with bending. So on our right, we have first metatarsal bone. On our left, we have the proximal phalanx, and here between, we have a sponge. A sponge that, as you see, is not moving away from the bone. It is stable because it is adhered to both ends of the bone. My main indication for RegJoint treatment is chronic luxation or subluxation due to chronic massive plantar plate tear. And I will tell you that I rely hugely on this implant for such indication, because I know that the stability after 6 weeks will never go into luxation anymore. So this implant adheres to bones, both sides of the bones, remains attached, and as you see, I will finally go through for the final time. It acts like a spacer, like a sponge, like something that permits a really good range of motion. So you see, those two cases that I mentioned in the first ray were both extremely satisfied, but here you see Valenti arthroplasty, so sometimes it is nice to resect a bit more on the head to allow for a good range of motion. Of course, in case you need to revise this, you will have to do a little bit more difficult reconstruction in case you would want to fuse, especially those ladies who have a lot of need for the high heels. Here in the Mediterranean, this is still very popular, so they tend to destroy even interpositional arthroplasty after 7 years usually. So then we like to fuse them, and then they stop with this need of high heels. I hope in the north female patients are much more smart than here in the Mediterranean, where appearance is everything. So a case after nice fusion, but degenerated IP joint, and it can be done like this. So we did takedown of the MPP, IP fusion, nice resection, and you see nice range of motion. Another Lisfranc indication, you see untreated Lisfranc ligament injury went to fast arthritis. Fusion 1 to 3, arthroplasty 4-5. This is now more or less my main approach, 1 to 3, plantar lapidus plate, dorsal, 1 screw on the third, arthroplasty 4-5. So the CT, which was done to assess the bony healing, shows a nice gap, and the lateral column was nicely adaptable to the uneven terrain. Okay, so the final case, just to convince you what can be done with the use of this nice off-shelf implant. Why is it important to have something that you take off-shelf? I know it is expensive, it costs some money, allografts are more expensive, but the donor site morbidity is 0. And in such complex cases like this one, of course, you don't have so much soft tissues available to take all of soft tissues from foot just to do arthroplasty. I think it is impossible. So this lady came to our clinics. She visited 2 surgeons with foot and ankle experience before, and both said we can only do TMT amputation. Of course, TMT amputation is the worst surgery for an active patient. TMT amputation, I think it's worse than the below knee amputation. And of course, patients are now informed, they read on internet. So she refused the amputation and she said, can this be preserved? Of course, we always think about the same principles, and you have to think always the same, where are we gonna do our reconstruction? And of course, main question is, where is this metatarsal shortening point popularized by Samuel Baruch? And here, I think this is it. So the metatarsal shortening point is the most shortened, the most deformed point of the most deformed ray of the most deformed foot. And this star marks the shortening if you want to do toe correction without loss of toes due to stretching of vessels and everything. So we planned our surgery to shorten the foot a lot. So usually our approaches are standard approaches. So we try to go 1 incision for the first ray, 2nd incision for the 2nd and 3rd incision, 4th, 5th, or sometimes we go from the lateral side to the 4th and 5th. But mainly this is the normal approach, dorsal approaches like Duvry described. But in this case, it is decided for the plantar approach that was popularized for the rheumatoid patient, as this one was. So this is what we did. As you can see, the foot shape is normal. The toes are aligned. The first ray is stable, so the patient has good force of propulsion. And the lesser rays were all salvaged and all mobile. And this is the final normal appearance of the foot, which remained so now for 10 years. Later, we did the 2nd foot in exactly the same manner because the metatarsal shortening point is universal for both feet. Then the patient, of course, has 2 sizes smaller foot than she had before, but now this is aligned, stable, unpainful, shottable, and aesthetically extremely pleasing. So the patient was very satisfied. With those case presentations, I hope I convinced you that RegJoint is a very, very useful tool. Of course, you might not be a massive user as I am, because you might not have so revision-oriented practice. I think I use about 50 implants per year, which is, of course, a lot of money, and our administration, of course, is doing everything to get reimbursement and things like this, because, of course, as a revision center, we have special ways of funding. But in some cases, I really encourage you to think about use of this implant, especially if you have more joints involved, or if you have a patient that would love to have good range of motion that would enable him more or less normal function. Be aware of the pain that comes if you do too much of range of motion exercises too early, but otherwise the complications are so little that it is very rewarding and very, very, very successful type of surgery in those cases that I showed you. Thank you for your attention.
Great, that's fantastic. Thank you.
Okay. Thank you very much, Jurij, for your very interesting and presentation with a very wide scope of different kind of patients. And now we have, if the participants of this webinar would like to have some questions to you, now this is the part where when you can ask. So Tia is sharing the turns to these questions. So please, you can send a message, or you can open just your speaker and talk.
Let's see.
Let's see.
Any questions from our participants? Very nice talk. Fantastic. Henry was writing this.
Thank you, Henry. You might be interested in post-op rehabilitation.
Henry is still saying, I have used this in the first and second MTJs. Also tarsal
coalition. Very good indication. Yes, very good indication. In pediatric cases, also safe use, and this is good use. Tarsal, exactly, very successfully. Thank you, Henry, for sharing your experience. My experience on tarsal coalition is the same. Thank you. Okay. So rehabilitation of those patients, I like to put them in post-op shoe. Catherine is asking.
Yep.
Hi, Jurij. Do you hear me?
Oh, hi, nice.
Yes.
And we hear
it's nice to see you. I'm not in the shape for a video today. One question. You do it to the TMT 4 and 5.
Yes.
And what about the rehabilitation? A full weight bearing after this, or
no? In TMT, I tend to do partial weight bearing, but okay. I think in isolated 4 or 5, I would let them walk after 3 weeks.
And do you a normal forefoot loading shoe or an air cast walker?
In TMT fusions, I use the same stiff sole rocker bottom post-op shoe I use in all for foot.
Okay.
But in TMT, I usually use crutches. Of course, if I do fusion 1, 2, or 3,
then short walker.
No, isolated lapidus for me is immediate foot weight bearing if I do plantar plate. If I do 2, 3, I go for I let them do the range of motion exercises in the ankle joint, but I don't permit the weight bearing. So I unload And usually 4-5 is limited because of the 2-3.
Okay.
If I do isolated, I would just leave them 3-4 weeks, partial weight bearing and crutches, then full weight bearing is tolerated.
Okay. Thank you very much. One question. Do you have any experience in elder people who have arthrosis in TMT2, and
Yes.
you don't want to
Yes.
to make a fusion because you don't want
It's not
to give
healing.
them clutches? If there is a possibility to do the RegJoint instead of fusion at
Yes.
TMT2?
Yes.
Okay.
And it is extremely rewarding.
Yeah.
Because the pain is gone immediately.
Yeah.
Usually you let them walk immediately.
Yeah.
And they never come back.
Okay.
So for me, if I have, let's say, a 60-year-old female with TMT2-3, I would go for fusion.
Yeah.
If I have 75 or 80, I would go conservative. But if I have to operate, I go for arthroplasty immediately. Big resection, big gap, so you get implant really nicely inside. The implant should not be squeezed. Because if you squeeze the implant, the function goes away. But if you have nice resection, I usually do slight resection on the cuneiform, a little bit more on the metatarsal, then I just put inside the implants and I suture soft tissues over it, immediate weight bearing, and very happy patients.
Okay. Thank you for your speech, Jurij.
Thank you. Thank you.
So, anyone else?
So I talked about rehabilitation. Usually I use K-wires. I like K-wires because then I control the position. And then, of course, patient is put in a stiff sole shoe, which is rocker bottom. So it is the same shoe I would use for hallux, for fusion of MTP1, for velosteotomies, for everything. I always use stiff sole shoe, rocker bottom, so that the K-wires are not bent at the level of MTP. And of course, the wounds have space to be covered. The wounds can be covered and there is space in the shoe. So all these sandals available from Darko or similar companies work nice. But the sole should be stiff, so there's no motion on the MTP joint line.